Thanks very much. I'm really pleased to be here and taking part in what is looking like a fantastic program. And I was reflecting on, this whole movement in healthcare in the last probably 10 or 20 years, mostly, about using national audits as a tool for improving healthcare, which I think is a really interesting topic. It's perhaps something that isn't very much in the public domain. This mechanism by which we set standards and then audit standards and feedback to units to improve care. Because when I was a medical student, which is a long time ago now, we were just kind of told what to do, and there was maybe some local protocols, or there were some guidelines kicking around, but you never really questioned it or kind of given it to do. And now in fast forward decades, literally decades, sadly, since then, I'm in this interesting position of working with the steering group in the Scottish Hip Fracture Audit, and working on the wards. So, and seeing that the standards and what we do comes from somewhere. It doesn't just get handed down tablets of stone, that's always evolving. And being in the steering group, which actually takes research, takes wisdom from frontline practitioners. We discuss, I'll just mention that in the talk later, and then generates, new ideas, new ways of working. And then that then spreads into practice at scale, so potentially tens of thousands of people in a single country will be affected. And if it's a bigger country, like Japan's just started, had a hip fracture audit for a while, but it's just changed the way it works with a best practice tariff, that hundreds of thousands of patients will be affected by a small group of people deciding on what should be done. So it's a really interesting area of work. So today I'm going to kind of describe the hip fracture audit, focusing mainly on Scotland and why we have audits, what they do, and the future. Start with a bit of background. Why do we have it? Why do we not just have wards with hip fracture patients with practitioners working? Okay. It's on, but I don't have any control over the volume. So maybe if I flip it, is that better? All right, sorry about that. So hopefully you managed to hear some of what I was saying, but to talk about why we have it, why we have hip fracture audit, how we run the Scottish Hip Fracture Audit, which is paid for by taxpayers, who the money is channeled through the government and into various expenses of mostly staff. So why does the government choose to allocate the funding to make that happen? Some of the research that we've been doing, and then I'll finish with some discussion around the fragility fracture network. So the story of hip fracture audit kind of starts with observations, probably dating back many decades, but start to appear in the literature in the 60s and 70s of just how bad it was, to have a hip fracture, especially when you were old and frail. This was a neglected condition with people lying on bed sometimes for 4 or 5 days, waiting for surgery when it could be fitted in around elective surgery, without any medical input, with minimal, care about this. And people started noticing this, and this was one of the early articles in the British Medical Journal by an orthopedic surgeon who described a model of care that him and a colleague in geriatrics had set up in their ward. And there's a multidisciplinary, if you find the article and read it, it's really interesting because it sounds very reminiscent of what we're doing now. A team-based approach, get people out of bed as soon as possible, manage pain, treat people humanely, and aim to restore somebody back to the function they were before the hip fracture. It's quite an inspiring article, actually. But you can see that we had a lot of problems with a lot of people not having an operation, just being left. That's very, very different now. Extended fasting, as I said, very high rates of renal failure, kidney failure. So the first national audit in the world was in Sweden, and this practice was noticed and spread across single units across Europe. And then Colin Curry, who's a retired geriatrician, in Edinburgh, went to Sweden and came back with 4 floppy disks. Those of you who remember what these were, which had the kind of details of how the Swedish audit was working, and he set it up in Scotland. He worked for many years as a kind of advocate for funding and arranging things at the health board level, to the point where we have a national audit in Scotland. So Colin really deserves massive credit for that. He also contributed to the setting of audits in many other countries. And a very big landmark also was the National Hip Fracture Database in England, Wales and Northern Ireland, which is a huge audit, biggest probably, well, the Japanese one's probably bigger numbers wise, but the NHFD is very impressive, established, huge audit, which has made a huge difference to hip fracture care in other countries in the UK. And now there are 17 audits in 20 countries. There is a huge variation among these audits, with various things being measured, like length of stay, access to geriatricians, mortality rates. Most audits only have a small number of standards or variables that they measure. Scotland actually probably has the most of any of the countries. There are multiple funding models. In Spain, for example, hospitals are required to raise their own funding to do the audits. In Scotland, we probably got the best funding model in terms of the government just funding it and making it happen. In England, they use a best practice tariff mechanism where hospitals get paid if standards are reached. So that motivates the hospitals to employ the staff to make the standards be reached. And the amount of money involved is large, and it's probably more than it costs to reach those standards. So that works really well as another way of incentivizing hospitals to do the work properly. So why do we have audit? Well, there's a lot of different reasons. I think one of the things to mention is just the sheer complexity of hip fracture care. It's one of the most complex conditions in hospitals. I mean, I would say things like, liver transplant. Transplant surgery is obviously extremely complex as well, but there are, not many conditions, speaking as a doctor who's worked for, several years now, that really compare with hip fracture in terms of the number of processes, staff, variables involved in successfully looking after somebody with hip fracture and getting them home and in good shape. It takes a huge amount of work at different stages in the patient journey to get there. So that's one reason that if you've got all these different members of staff, you've got lots of different variables in the system affecting that there's huge room for variability. And that's what these early studies showed. There was massive variability in how quickly people got to theatre to have an operation, what painkillers were used, how much physiotherapy they got, how long they stayed in hospital, the rates of discharge back home or newly needing a care home. So the variability must show that some of it is not optimal. So that's why, there's so many different things it needs to. This is one of the reasons why it's so complex that you can't just let units run using their own processes and hope that it's all just going to align magically. You have to measure things and improve it. So I think that's probably the main reason why we have hip fractures, just the sheer complexity and the variability, and that variability matters a lot. I mean, this is just from my perspective, this is what I do day to day on the wards, where, somebody who's fallen has a lot of variables about them before they came in that we need to assimilate. And then after admission, there's lots of acute problems that can arise. Pain is almost always present, delirium, very common, infections. So it needs skilled medical care to diagnose and treat all these conditions. But that's in parallel with loads of other, specialists, physios, nurses, OTs, others, pharmacists involved in characterizing each individual, understanding the problems that they have and trying to address them as quickly as possible. So this is a very interesting study from 2005. And a couple of things to note about this was that the 30-day mortality was 13%, which is quite an amazing thing, really. I mean, more than 1 in 10 patients not surviving. Now the mortality rate in the UK is 6 to 7%, so it's been cut in half since 2005. 2005 wasn't that long ago. It's even that, I think, is a startling finding, isn't it? And another startling finding from this paper is that about half of patients had what they analysed as being avoidable deaths. So these were patients who did not get optimal medical care, optimal nursing care. Various things were not done that should have been done when each case was analysed very closely. So that's another driver for saying, okay, so if people with hip fracture who are often very vulnerable, older people with frailty, if they're at high risk of getting complications that could end their life, and we know that good processes and good expertise can reduce that mortality rate a lot, then we should make sure that that care is being delivered to these people. So that's one big reason for having audit. Other reasons are that they work, that simply by monitoring and feeding back to units, we know that it will change the behavior of most centres, just simply knowing. And that's something that anyone here who's working in healthcare will completely understand that. If you're being sent a memo saying that our length of stay in hospital X is twice as long as hospital Y, or even our ward is twice as long as other ward, or this ward is getting much less physiotherapy than that ward, then that instantly becomes something that you care about, isn't it? You think, why is that? Can we improve that? So there's an urge, because most people come to work in healthcare want to do a better job. So is that information, which just isn't there normally, fed back is enough to stimulate a lot of activity, and we know that it changes practice. So benchmarking against other institutions locally and also across the world, standardization of practice. So this is what we do with these patients every time, unless there's a reason not to, and then measuring that performance against the standards. And we know from lots of studies now that hip fracture care, when it's audited, the audit costs a little bit of money, but it's very cost effective, and it also improves quality of care in quite big ways. So this is a very well-known figure from, the data are quite old now, but this is the National Hip Fracture Database in England, Wales, Northern Ireland, and this paper very carefully analysed an independent analysis of data showing that they attributed the huge drop in mortality, almost halving of mortality at 30 days, due to changes that the audit had stimulated. So, this is real. This people are walking around. These people who would have been in this bit of the graph were going home or alive, rather than not being alive. That's how serious it is. And another reason why we have audit is because, and we need to keep working at it, is because of the demographics. And this has just been accepted actually for publication, but some members of the steering group have modelled projected rates of hip fracture in Scotland, and it's amazing what these figures show. If we look at where we are now, and then really tangible increases in the workload coming through our hospitals, and that's something that the steering group in the Scottish audit is having to take account of. Like we don't want to wait 5 years when there's the Royal Infirmary is going to go from 1,200 to 1,500 or 1,600 with the same staffing and the same accommodation. We need to adapt now to anticipate these changes coming. So that's another reason why we need to work very hard as a society. The number of patients in the Royal Infirmary with hip fracture is quite high. I think 40 or 50, maybe sometimes out of the 1,000 beds. So it's a significant percentage. And patients with hip fracture stay in hospital quite a long time compared to most. So the bed days of hip fracture patients is already very high, and it's going to really affect lots of other processes in the hospital, as well as being bad for people if they don't get good care. So now just go through a little bit more detail about our audit here. So as I said, this was started in 1993, the second audit in the world after Sweden. There were some decisions around funding taken in 2008 that were controversial, but the audit was shut down as a national enterprise in 2008, and internal monitoring. But it took a lot of the teeth and the power of the audit away to do that. And in fact, studies that were published after that showed that standards which had been improving steadily from 1993 to then stopped improving, and some even got worse. And then the year that followed the reintroduction of the national audit, there was an uptick in many of the standards. So it's a strong evidence that, that just simply doing this audit and reporting back, setting standards really works. And now we have a full audit, which is, some people say it's the most comprehensive and accurate audit in the world, because of the funding model, because we have the most standards, and we've still got a lot of room for improvement, don't get me wrong, but I think we have come a very long way and now operate, I think, a very good audit that's maybe realised some of its potential, but I think there's a long way still to go. The steering group is the beating heart of the audit. This is a national group that meets quarterly, and we always meet online now, and we used to be a physical meeting pre-COVID, but we decided to make it always online because we are such geographically distributed. So it means that people from Shetland, Western Isles, and other places which are far away, they can attend the meetings instead of taking 2 days out to come to attend a 3-hour meeting. So it's working a lot better now. It's a fantastic meeting, full of beans. The people that are contributing are a mixture of frontline staff from all the disciplines, as well as government analysts and policy people who understand how ideas the steps of how they might get translated into audit. So it's a really fantastic, I really enjoy that meeting. And we also run an annual educational webinar. Now, my colleague Andrew Hall characterised the practice of the audit as a performance trifecta, which I thought was a really interesting way of looking at it, because it sort of embeds in your mind that there's 3 things that we do, not just measurement. I quite like it, so I've decided to use it for the first time in this slide. Because I like the idea that we set the standards, we measure and report the standards back, but we also have a significant research element to what we do using the data that the audit generates, plus linking it to other stuff. And these all feed off each other, creating a kind of critical mass and feed forward cycle. And so the standards there's 12 different standards. I'm just going to run through them in a little while, but that's just to introduce them. The funding model costs about £500,000 a year to run. This is the last set of figures. It might not be quite accurate now. And the budget covers essentially the salaries of mostly it's about the salaries of the staff who collect the data in each hospital, and the analysts and managers who run the audit from the Scottish Government, from Public Health Scotland. Now, the data collection is something that we're very proud of. We have one of the local audit coordinators here in the audience, who works in the Royal Infirmary, and they're mostly nurses, but it can be administrative staff with appropriate training. They're a very highly trained group who audit every single patient who's had a hip fracture in a Scottish NHS hospital, line by line, against the standards, using a very detailed process. And there's a lot of supervision from analysts in Public Health Scotland. There's a lot of interaction, and there's a kind of checking on a real-time basis of all the data that's flowing in to make sure the data are valid, correct, and we have more than 99% of patients included, validated by this extremely high quality audit. It's probably the highest quality that it's possible to get, because the staff doing this know about clinical practice. They know how to read the notes. They know how to enter the notes. So we can trust the data that are coming out of the audit. Another thing that's really important is that once the data have been verified, that's usually a question of small number of weeks, it's fed back on a real-time basis to all the centres around Scotland. So even although we have an annual report, each centre knows in a very high degree of detail how they are performing against the standards. And that result, I work on the wards in the Royal Infirmary, so I'm the recipient of this as well as somebody who organises doing it. It's very powerful because we can get a memo saying the number of exceptions to the standards was high last month. Why was that? And that could be, for example, that 2 physiotherapists had left post or were ill, and we weren't able to replace them in time to get people mobilised again. So that creates a set of actions very quickly. It's not an annual thing. That's happening on a real-time rolling basis. It's also very important for quality improvement work, because it means that we can use this, lavishly, collected, detailed data that's happening through the audit as a basis for QI projects. Otherwise, we'd be getting staff to do QI, which many people here must have been involved in quality improvement projects, but it's quite labour intensive, to do this kind of work. So we can harness the audit data to make changes, and then just it's automatically being connected. So it's a very useful thing to do. Another thing auditors do is that they often give informal feedback about what's happening on the sites. Like they may say there's a real problem here because of X, or that is also useful intelligence. It's not spying on centres. It's all about trying to ensure that we're doing all we can to help centres reach the standards. But that's very useful. And sometimes we ask auditors to collect extra data because they're thinking of changing a part of a standard or introducing a new standard to see what the baseline is, and that might not be reported in what we produce in our reports, but it's a very useful baseline. So it's used in it's a very powerful tool. In many other places, local hospitals collect the data themselves without necessarily the funding and support that we give, and the quality, I think, is definitely lower, and the capture is lower. Most places 70 or 80%. So we're lucky to have this, and I really hope we continue to have this as a key tool in the audit. We have 12 standards, but also key performance indicators, and these are very important because when there is a deviation from expected performance, or when it deviates away from other centres, this triggers a process which I'm not going to go through all of the steps now, but it's quite a serious thing. When there's underperforming unit, we will interact with them usually just initially by email, but the medical director of the health board is informed, a letter goes out, and then there's discussions around what's happening. Is there a problem? How can we help? The clinical team investigate why there's a deviation, an action plan is produced, and then this is re-audited. And occasionally this escalation process happens. So this is much more carrot than stick, but there is a stick, because we expect that the standards have to be adhered to. So mortality rates are going right up in a centre. We'll have to say, why is that? Sometimes it might just be a fluctuation that's happened because more, a sicker cohort of patients happen to have come through at that time. But it might also be because, something serious is happening, like staffing isn't appropriate or something like that. So it does have this backup of compelling, change when things are not going well. So this is an example of the funnel plots that we use, and standard deviations are, departures from the mean across Scotland. And this is for access to geriatrics within 3 days, and several centres are below the line, and this triggers what's happening. In fact, there are major problems here because we don't have enough supply of geriatricians like me, or even advanced nurse practitioners with training. So rather than saying, well, it's impossible, let's not do it, we're now looking at ways of structurally changing how we train people to make sure that we do have the supply of people doing this. Another important thing that we do is peer support. So I've done several of these where, actually physically go to the centre and have a meeting, usually lasts about 3 hours, where the centres present various pieces of data, their staffing models and so on. And then, we try and bring the collective, because usually several members of the steering group will go from other centres, bring the collective experience that the steering group has on, like, well, in centre X, this happened, so they did this. And I think this is a very useful way of supporting centres to continue to look at their practice and not drift into a situation where the care is worse. And as I say, there's a formal governance process that can be triggered if there isn't an improvement within usually about a year, maybe even half a year. So I'll just quickly run through the standards. Because of time, I'm not going to go into much detail. You can find all of this it's all publicly available on the Scottish Hip Fracture Audit website. So transfer to ward within 4 hours. What we call the big 6 has to happen in the ED, the emergency department, or A&E, before people come up to the ward. In the ward, we do 4 things mentioned there. We also recently have increased what we do with nutritional assessments. So we don't just assess, but we supply nutritional supplements to every patient. And this was an example of what I said before about not just having policies handed down to you, but actually creating policies, because there was a lot of discussion in the steering group about the fact that we knew that a lot of hip fracture patients were malnourished when they came in, and when they come in after that period, most don't eat enough because they don't feel well, because they're fasting, because many have delirium and they're not interested in food, and maybe don't have the wherewithal to ask for food if they're hungry. And although there are not any large RCTs, there have been several observational studies and some quality improvement projects showed that it was, possible to deliver much more in the way of calorific intake to people. We knew that it was very important. So now in Scotland, all hip fracture patients are given nutritional supplements, drinks twice a day. Not all of them get drunk, and many people eat normally, they don't want them. But the way that pragmatic healthcare works is that this is now offered, and we're now auditing how much gets consumed, but we're confident that the calorific intake of thousands of patients has been changed by introducing this policy. So that's an example of how talking in a room with a few people, reviewing evidence, learning from other centres, in Northumbria and Cardiff had introduced this, and some opposition because of the lack of RCT evidence, but I think a common sense, pragmatic decision about this being a low cost, simple intervention that makes sense, was introduced. So we measure against repeat fasting. People are now able to sip. There's another change this in the audit and in the practice. So people are now able to sip water up until a point that they're sent to go to theatre. So this was introduced just over a year ago, I think. Came from an anaesthetist in Dundee. It's now spread all over the world. What the anaesthetist said, why are we doing this? Why are we making people not have anything to drink at all? Is that really necessary to be so restrictive? And so a lot of work got done, a lot of scholarship happened, and there was consensus amongst a lot of different relevant people that it was okay to give people sips of water. And I now see that, I ordered yesterday, giving somebody a sip of water, their mouth's so dry they can barely speak. They've still got maybe 4 hours to wait till their surgery. It's just such a nice thing. You can have a sip of water and suddenly they just feel much better. So it's humane. It's also slightly helps with hydration and so on. Surgery within 36 hours, that's quite an old standard. Many centres around the world have that. Many audits around the world have that. Cemented hemiarthroplasty. And then input from a geriatrician or an appropriately trained other practitioner, which could be a GP with a special interest, or it could be an advanced nurse practitioner within 3 days. Mobilising by the end of post-op day 1 by anybody. So that could be a nurse or a physiotherapist, and physiotherapy assessment by post-op day 2. OT assessment by day 3 post-admission. Bone health, which Alison Black will be speaking about next. Alison initiated that with colleagues in Osteoporosis Society in Scotland, and it's been a lot of work to make this happen, but now it's happening in many centres that people are getting bone protection administered within a few days of surgery instead of being referred for a DEXA scan and waiting sometimes months or even years before treatment was started. So this is an important step forward, and I'll talk about that a little bit more later. And then we aim to try and get people back home within 30 days through this MDD approach. Some studies around the world have shown that the degree to which standards are adhered to correlates with the outcomes in patients. So this is quite an interesting way of studying whether these things work. So this study, which is back in 2018 from Luke Farrow, was a surgeon in Aberdeen, on the steering group, showed this. We're now repeating this because we can measure, because the data we have, we can measure in quite a lot of detail how much the standards are adhered to and relate that to outcomes. This is another analysis that's in preparation. Hopefully it'll be published in the next few months, showing that if the standards are adhered to, it saves bed days. And if you look at how that impacts on costs, the cost of monitoring these patients is very low compared to even saving just a handful of bed days. I think a bed day costs £400, something like that. So if you shave off after a few bed days, you're saving an enormous amount of money. And, you know, auditing, I can't remember what the unit cost for the audit, something like £30 per patient, the audit costs. So it's not that much in relation to what we're trying to, it's not just about quality of care, that's actually saving money. So that's really good to see. But this is an important argument that needs, because every year the government's saying, do you really need to have the audit because of the cost? And it's reasonable. I mean, £500,000 of taxpayer money is a lot, and the government has to spend that money responsibly and choose it as a priority over many other competing priorities. But we have to show that this is an area where, you know, investing in the audit saves the NHS a lot of money, as well as improving care. And this is a quote from Colin Curry that I dug out of a paper that I read recently, and I really like that. And that actually is quite a chilling thing to say when you think about all the other areas of care that we don't audit. You know, there must be massive variations in access to care in other areas. Hip fracture is a kind of focus, but what about lots of other aspects? So in fact, more data, more scrutiny, more management, and people in the press, somebody say, "Oh, we need to slash NHS managers and you know, cut down the red tape." The NHS is actually a very undermanaged organisation in relation to how much it spends and the stakes. You know, and having more management from people who know what they're doing, more scrutiny, more data, is actually probably going to be better than having less. That's my strong belief, having worked with many managers, and I think it's a weird thing in the press that, you know, this is the sort of easy go-to target. Let's cut down the managers. You know, the managers every day are working to make sure that services are delivering the things that, you know, we're supposed to be doing. So in the last year or so, year or two, and also what's coming up in the audit, so we've shown that giving intravenous fluids from diagnosis in A&E reduces the rates of renal failure, acute kidney injury. So common sense thing to do. Many people with hip fracture, they have delirium, so they're not able to ask for drinks or reach for water. They're stuck in trolleys, often for a long time now, unfortunately. And often arrive dry because they may have fallen. They're lying on the floor for hours, can't access water. They also bleed, you know, into the wound. So that's another source of loss of water. So it used to be said that people with hip fracture would get acute kidney injury in up to 25% of cases. You know, in Edinburgh, it's about 5 or 6%, you know, and mostly it's not because they're dry, because we haven't given them enough water. So that's the sort of thing that we've tried to do. Nutritional supplements, I mentioned, SIP Send, bone health, which I think I'll let Alison talk about in more detail in the next talk. But, you know, giving vitamin D and IV zoledronic acid is a really big step forward in reducing the risk of secondary fractures, because nearly all of these patients will have osteoporosis. And we know from audits, this audience I'm sure knows this very well, that the treatment, the delivery of treatment to people with osteoporosis is woeful, you know, because people don't comply, they don't get access, no one ever talks to them about it. So this is a very important step forward, and we hope this will mitigate some of that curve, because a lot of fractures that we see are secondary fractures. People fall again. And if we can reduce these even by a few percent, not only is that fantastic for the patient themselves, but it's also better for the healthcare system. A national advisory pain protocol, because we discovered lots of variation in practice. An educational website, which we're expanding all the time, again, to provide support to reach the standards. And then, you know, in the next few months, we're going to be holding some meetings to discuss strategically how we can not wait till it's happened, but think about how we can improve the staffing, especially of people, you know, with skilled in geriatrics around Scotland in the different wards, to prioritise this care, because we know that it works. So these are just some examples of snapshots from the screenshots from the website. So clinical practice statements, which can be downloaded by anybody. This was some work done on optimizing anesthesia protocols for hip fracture patients led by the same doctor who introduced SIP Send. So that was very productive, because again, we found lots of variation among anaesthetists and what was done during surgery. And this article came out, Alison led the Scottish element of this, and then in England, Wales, and Northern Ireland. The National Osteoporosis Guidelines Group produced their guidelines just after the Scottish ones, and I don't think there was much crosstalk between the two groups, but the advice was very strongly aligned, which is encouraging. And also in Ireland, you know, there was a move to do this. So this led to this paper, which I was the only sort of non-bone specialist in the group. I was kind of giving the voice of the geriatrician in the street, and the rest were all, you know, I had some disagreements, but eventually hammered out a consensus around a broad approach to making sure that hip fracture patients get IV-Zoll where it's safe to do so in the hospital phase of care, which then would last, in some patients, you know, a lot of the effect lasts for nearly 3 years. So it's a very effective, and hospital is a good place to give this kind of treatment because we've got all the staff and facilities. So just now to turn to some examples of research. I'm not going to go into any detail about this. So this is another paper led by Luke, showing quite a lot of variation in how much different units were giving blood post-operatively or sometimes pre-operatively, and outcomes in relation to that. So quite an interesting study, which often this kind of work requires studying what's happening and then drawing conclusions from that and then deciding what to do. So this is the first step in that, just showing variation, which is probably means that some people are getting blood when they shouldn't get it, or some people should be getting it and they're not. So trying to understand that process and having better decision making around that. And there is a randomized study going on at the moment, which hopefully will help to answer that question. This was a study that led by Andrew Hall, who's a PhD student of mine, finishing in November, and he had led a whole bunch of studies called the impact studies, looking at impact of COVID on hip fracture outcomes, but also on service provision and so on. And this is just one of the examples of the studies that came out. This is another one led by another PhD student, Rose Penfold, who's working with me in Edinburgh University now. And this looked at delirium, so acute confusion in people at the front door, so in the ED and A&E, measured by the 4AT tool, and finding that it was very common and also was strongly associated with bad outcomes. Scotland's is the only registry in the world that advocates for delirium screening at the front door, which is remarkable because we know that 1 in 5 patients have it when they appear in A&E, and it's a condition that we should diagnose without any doubt, you know, in terms of informing patients and their families that they have delirium, because it can be a very frightening thing, but also getting them into the right management pathway and so on and so on. So I think this work is going to be influential. We've got another study coming out, which is of 18,000 patients across Scotland, showing similar findings to this, not just in the COVID period of time as well. So we're hoping that will influence practice across the world. And the potential of this is enormous when you think that if you can demonstrate that delirium is common, that it's measurable, that it affects outcomes, we should be saying that this is introduced across the world in hip fracture care. So that could affect large numbers of people in a good way. This was another example of how international collaboration, led again by Andrew Hall, but impact studies, trying to harness lots of centres around the world to report the impact of COVID on hip fracture care. Very interesting study, showing quite a lot of variation in different studies. So these are some of the studies. We've got many new projects in the pipeline. I mentioned about, you know, does adherence to standards help us improve outcomes? That's an important thing that we need to do. Outcomes of delirium, as I mentioned, we're in a position where we can link to other. Scotland's a very data-rich country, one of the leading countries in the world for data capability and also analysis of what we have. And this is leading to a new wave of PhD students and others working on this data, collected by a lot of it collected by the local audit coordinator, because we can trust it because it's high quality. So just to conclude, this is more like a kind of advert. So I recently joined the executive committee of the Fragility Fracture Network, which is a global organization, and I attended the meeting in Oslo a couple of weeks ago, which is fantastic. About 600 people came. This is a wonderful organization, which I think is at its heart is a humanitarian organization. It has a mission, and it's very devoted not just to Western countries or industrialized countries, but to, you know, low and middle income countries, to look at hip fracture care across the whole world and encourage better care through provision of resources, through helping people set up, you know, audits, and being, I think, you know, honest about how variable and often how bad the care is in some places still, just like we were a few decades ago, sharing those insights so people don't have to go through this whole process again. The next meeting will be, I think it's in October 2024 in Istanbul, for a regional meeting. They have global meetings sometimes and sometimes regional meetings. And this is the hip fracture audit page, which is a very powerful mechanism for bringing together people from all different backgrounds and countries to share practice and move things forward. Looking at not just comparisons among hospitals and countries, but among countries. How are we doing with respect to mortality rates? Or what do we have in our standards? This paper that came out, led by Anthony Johansson, who's medical lead of the National Hip Fracture Database, Andrew Hall again, and a few others, trying to get a common data set for certain variables in practice, which are listed there. Oops. I'll point to that. So trying to get these standardized so we can compare different audits and outcomes more cleanly. And creating and sharing resources. So this is from Asia. This shows the power of international collaboration. So this wasn't a UK or European initiative. This came from Asia, you know, how to implement good hip fracture care. And I really like this aspect that we're harnessing the brains of people from everywhere in different settings. Oops. Right, so to conclude, I think the story of hip fracture audit is a really interesting story, as I said, you know, from people noticing problems to documenting them to evolving into a set of standards to generating research studies. Scotland has been a leader, and I think, you know, I think our hip fracture care is steadily improving, and by international standards, it's very good, but that doesn't mean that it's as good as it should be. But it is very good in relatively speaking, and I think it can be happy about that, but also use that as a platform to continue being honest about where it's not going well and keep pushing forward. And I think research is going to be very important. This partnership between universities, you know, people in all sectors, all disciplines, using these very valuable, expensively gathered data and using that to inform changes in practice. The demographic changes we know will mean that real increases in patients will be happening. You know, we're already beginning to see that actually, so that already overstretched busy services will be even busier in the future. And I think that the future is bright, but also with respect to international collaborations. You know, anyone who's very interested in this area, I urge you to look at the Fragility Fracture Network website, to consider, you know, coming to the Istanbul conference if you can get the funding for that, or get involved in FFN UK, contribute audits, ideas, attend meetings, because it's a very powerful force for good. So I'll leave it there, and thanks very much for your attention.
Alasdair has time for a couple of questions if anyone has. Just to say that those who are going to the second cook-off session, it will start in about 10 minutes. So hang fire until the other people come back. Okay. Does anyone have any questions? Is there a mic somewhere? Oh, sorry, I don't know where.
Working? Hi, thanks very much. That was really interesting. I'm not in the health service, but I've been involved in physical activity for over 30 years.
Do you mind putting it your
Sorry.
microphone right here, because I'm struggling to hear you.
Oh,
'cause I think
sorry.
the speakers are pointing that way.
So I'm not medically qualified, but I've been in physical activity for 30 years and teach a lot of people that have had hip operations, et cetera, and now my research interest is hypermobility. And one thing that seems to be quite common is that people that are hypermobile tend to have lower bone mass density than people who are not, probably because we don't exercise as much. But the question doesn't seem to be asked in hospitals and on point of entry, any questions about hypermobility, which obviously, if you've got laxity in ligaments, can cause problems in resulting surgeries, etc. And just wondered why that is not a genuine question that tends to be asked.
I'm not sure that it isn't in all cases. I'm not a physiotherapist, and I don't know the detail of what physiotherapists are assessing, but I think that this is where audit can be very powerful. Like if we're not measuring it, and even if it's being asked, what is your level of activity, which I think is routinely asked, but the way that's asked and the way it's documented will be very different. Mm-hmm. I don't know if any physiotherapists here who work in hip fracture want to comment on that. No
it's
one's
perhaps even more in the context of.
But I think it's an important question, though, and I think that speaks to the broader issue of primary and secondary prevention.
Yes,
doesn't it?
And I think it's also. I did an FOI request, part of my undergrad degree, and asked how many people who'd had hip replacements within the UK. I got the figures from over the UK. How many people had actually been screened for hypermobility, because obviously ligament laxity in the joint, once it's been fixed, we can still cause problems. Bearing in mind hypermobility is roughly 20% of the adult population. And there was hundreds of operations carried out, if not into thousands, from the 2019 report. There was only 2 people that were hypermobile. I find that quite astonishing.
Yeah, I mean, it's obviously untrue. And, it's a question. I mean, I think this is a very important question, a very interesting question, and something that we'll think about. I wonder whether, again, it's the sort of thing that steering group could discuss, because, there might be people who are already doing some of this kind of assessment, but it's not making it into a standardized form in the notes, so we just don't measure it, because that could be an important public health message. That's what
I feel. Public health and hypermobility needs to be right up there. So thank you very much.
Thank you.
Sorry, the doctor always mention and emphasize of taking vitamin D3 rather than D. Is it because you mentioned vitamin D but not D3?
No, it is D3. It's just a shorthand.
So it should be D3.
Yeah, I mean, and Alison, who's speaking, well, she's on, I think, going to be on Teams, but well, if there's any additional questions about that, I'm sure she'd be happy to answer that. But it's just, I just say that in shorthand, but I'll remember that for the next talk.
Yeah, thank you.
To put this, I just wondered, sir, if there was maybe a correlation between osteoporosis and medications. I certainly know that a lot of people are being given stats now to reduce blood cholesterol, and I believe that these are bone thinning meds, and I reckon there's a whole lot of other medications that reduce bone density. And I was wondering if maybe because an awful lot of us have been given these medications now, whether you're going to see an increase in issues associated with these meds.
You're talking about statins?
Yes.
Yeah, I'm actually not an expert on this. I'm not aware that this is a widely held opinion, that anyone who's on statins will get osteoporosis. It's a good question, though. I mean, Alice, again, I keep putting this all on Alison, who I don't know if she's listening to the tail end of this, but in all the discussions we had, for example, producing that consensus paper, there's certainly nobody is saying that people with the need for statins should stop them, if they've got a diagnosis of osteoporosis. Whether or not there's a public health impact over time, which could then mean that for some people it's been a bad idea to take statins for that length of time. I just don't know the answer to that. But all I really report is that as from a perspective of geriatrics, a general geriatrician, I mean, my experience is more in delirium and acute care of hip fracture, but I wouldn't say that it's something that comes up very much. I think there's a lot of we have to be humble though, and never discount the possibility. But I think it's only going to be through high quality evidence that people would then, because statins have got such a potent positive effect, you know, on other risks. So, but thanks for the question, and I'll certainly look into that and see what the latest developments are.
Thank you.
All right.
Well, thank you for that presentation. I really enjoyed it, and it really demonstrated the importance of audit across multiple disciplines. I was struck by your list on your steering group membership, and you hadn't listed nurses. Are there nurses on that steering group? And if not, why might that be?
Yeah, of course there's nurses. I don't know why that's not on the slide. Yeah, I mean, the lead, both the lead for the Scottish Government, Kieran Adam, is a nurse. The Kirsty Ward, who's the clinical audit lead, is a nurse. And there's about another 5 nurses on the steering group who work in various roles. So nurses are probably the biggest number of people on the steering group, at least as common as doctors anyway. And we have lots of other, you know, specialties. But sorry about that glitch in this slide. But nurses are critical to hip fracture care. I would say they're the core staff. You know, the doctors. I would say that I'm one of the spokes, and the nurses on the ward are the hub. So that's the way I look at it.
Thank you.
I hope that's reassuring.
No, I just wondered because I think nurses, certainly, I'm a midwife now, but way back when, nurses then were a group, and I don't want to offend anybody, we didn't always push ourselves forward to things like that, and it's just to reassure myself and everybody else that we now do.
Yeah, I don't know why that's not there. I mean, what I would, just a final comment is that I think one of the great things about being a geriatrician, and I think also hip fracture care, is it's truly interdisciplinary. I mean, it's not just tokenistic, like let's just hear a few people telling us and then we'll decide. It truly is tokenistic. Something we need to develop more is actually involvement of, you know, patients and carers in shaping what we're doing. That's something that that's a trend that's happening now, and I know there's a lot of, you know, people who are not working in healthcare here in the audience. So I would just want to say that's something we're beginning to think about in a bit more, is working out mechanisms to get the voice of patients and carers represented in our work as well. So thanks for that comment, and I'm shocked that I didn't put that on the slide. Maybe it's so fundamental that I don't even think I need to mention it, you know.
Please, can we give Professor MacLullich a final round of applause? Thank you very much.